Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. And today I have the great pleasure of inviting to the podcast Dr. Francesco Fanfani and Dr. Virginia Vargiu. They are from the Department of Women and Child Health and Public Health and Fondazione Policlinico, Gemelli in Rome. The reason for this podcast is going to be the December lead article discussion titled Optimizing Patient Selection for Secondary Cytoreductive Surgery in Recurrent Endometrial Cancer. Virginia, Francesco, welcome to the podcast.
Thank you, Pedro, for this invitation to share with you and with the community our paper that now is in the next number of your journal.
Excellent. Thank you so much, both of you, once again. Lots of questions, and of course, obviously, an important and interesting topic that we want to address on this discussion. And first, I'll start with you, Francesco. Let's start by discussing what do the current guidelines tell us about indications for surgery, particularly today, in the setting of recurrent endometrial cancer.
First of all, we can say that management of recurrent endometrial cancer requires an MDT approach because we have many alternatives. I mean, surgery, radiotherapy, systematic therapy with immunotherapy. And so we need a very tailored approach in every single case. According to ESGO guidelines, surgery is primarily recommended when complete resection of all visible disease can be achieved with acceptable morbidity, particularly for isolated vaginal or nodal recurrence. For patients who have not previously received radiotherapy, external beam radiotherapy and brachytherapy can be an option. And in that case, postoperative chemotherapy should be considered, but level of evidence is not so high because it's 4C. Similarly, in the US, the NCC guidelines suggest radiotherapy or surgical resection. So we have most of possibility to be considered. For sure, we can say that the patient selection for cytoreductive surgery is the issue because we know, like for other gynecological disease, in particular ovarian cancer, that achieving complete gross resection is a key goal in the surgical management of recurrent endometrial cancer, since it is associated with significantly improved post-surgery survival. We previously showed this data in a paper published in International Journal, demonstrating again in a retrospective series that complete gross resection can really give benefit in terms of progression-free survival and overall survival. Systematic therapy is normally considered or recommended for patients unsuitable for radical surgery, or in patients in which we cannot achieve a complete gross resection. So I think that we really need objective selection criteria in order to better identify patients that may be selected for surgery in case of recurrent disease.
Excellent. So to that same point, and I'll go to Virginia now, some might argue that given such great options that we have available today for our patients with combination chemotherapy, immunotherapy, antibody drug conjugates, why even consider a patient for surgery and potentially actually delaying what some might argue is the actual treatment that they need?
Yeah, thank you for the question. Actually, immunotherapy, particularly in combination with chemotherapy, has shown promising results for patients with recurrent or advanced endometrial cancer. However, we must recognize that these results may not fully translate to patients who are surgical candidates. So first of all, we have to remember that surgery remains the first-line recommendation when complete gross resection is achievable, as it seems associated, as we said, with improved survival. And then we have to note that the trials examining the combination of chemotherapy and immunotherapy, such as the RUBY or the DUO-E or the GY18, included patients with recurrent disease for whom surgery was unlikely to achieve a curative outcome. And also, if we have to examine immunotherapy alone, we must consider that the objective response rate was about 45% in MMR deficient patients and 32% in MMR proficient cases. So the question, I think, that could be that whether the benefits that we see with immunotherapy, if these benefits can be extended also to patients who undergo and achieve complete gross resection. So since recurrent disease often have a systemic implication, adjuvant therapy, including also immunotherapy, might offer additional benefit even in cases when complete gross resection is achieved. So maybe we can see immunotherapy in combination with surgery and not just surgery or just immunotherapy alone.
Excellent. Very, very good. So we'll get started now talking about this particular study. Francesco, what was the study design here? What were your inclusion and exclusion criteria? And, certainly what were the primary objectives of the study?
So this is a retrospective multi-center Italian study conducted in 3 referral centers for gynecology oncology. Our inclusion criteria were very simple. Patients with histological and or radiological diagnosis of recurrency after surgery as first treatment for endometrial cancer patients. So we consider only patients submitted at the diagnosis to surgery for the diagnosis and with the treatment intent. And the exclusion criteria were patients without surgery at primary treatment, cases with concomitant primary cancer, or patients lacking relevant clinical, radiological, or pathological data, and non-epithelial tumor, so only endometrial cancer. Primary objective was the identification of preoperative predictors of surgical feasibility defined as complete gross resection. And secondarily, objective was to assess the complexity of surgery, which kind of surgery we need for achieve complete gross resection, and try to design or to propose a preoperative clinical radiological predictive score aimed to identify patients suitable for complete gross resection at secondary cytoreductive surgery.
Excellent. So now you talked a little bit about this predictive score. I wasn't as familiar with this in Virginia. I was wondering if you can tell us something more about this and what's the actual accuracy assessment of such a predictive score?
Yes, sure. Actually, the score that we identify that we design can be considered a useful predictive tool with a good ability to select patients suitable for complete gross resection, especially when we have higher scores. But actually, the score had some limitation in excluding patients with a low probability of surgical success. In detail, our score had a very high positive predictive value. That means that patients with a score of 2 or 3 have a very high probability of achieving complete gross resection, like 86 or 93% respectively. And that indicates that the score is effective in selecting suitable candidates for surgery when the score is high. On the other hand, we actually have a quite low negative predictive value. That means that for patients with a score of 0, a significant percentage, that is actually the 33% of the population, still achieve a complete gross resection. This implies that the negative predictive value is not particularly high, and the score may not entirely exclude patients who, despite having low scores, could benefit from surgery. Overall, generally, the score has a quite good sensitivity and specificity with an area under the curve of 0.74 that suggests that the score has a good ability to distinguish the patients who are likely to achieve complete gross resection from those who are not, even if the specificity is stronger for higher score. In summary, so our score is a valuable decision support tool for selecting candidates for complete gross resection with a very good ability to discern patients with a high chance to achieve gross resection.
Okay. So now, before we actually get into the results, I wanted to ask Francesco, in the methodology, you mentioned that radiation therapy was evaluated for all patients who had not undergone radiation treatment previously. So what criteria were used to decide for surgery in the setting where radiation was feasible? In other words, were there patients where radiation could have been a very good option, but instead you chose to do surgery?
I think it's a very critical question and issue. We know that evidences comparing radiotherapy and surgery in radiotherapy naive patients are limited and mainly retrospective. Some authors are in favor of better prognosis in patients admitted to surgery compared to radiotherapy, but very scanty data, no prospective trial, no randomized trial. We usually consider radiotherapy for patients with small vaginal recurrence, for those unfit for surgery due to comorbidities, or in case when radical surgery, I mean exenteratio anterior and/or posterior, is required for curative purpose of recurrence disease. However, we have also to consider the balance of the potential immediate benefits of radiotherapy versus the potential advantage of spare radiotherapy and to operate in a non-irradiated fields when you have low risk of complication and better surgical results.
Excellent. So now, Virginia, let's get to the results. What were the results of the study? And what are some of the points that you really would like to highlight?
Yes, so actually the study provides valuable insights into optimizing the patient selection for secondary cytoreductive surgery. The key predictors that we identified were age under 65 years old, a single site recurrence, and a specific patterns of spread, actually the lymphatic patterns and the hematogenous one. These characteristics were significantly linked with the likelihood of achieving complete gross cell reduction. So patients with these characteristics had notably higher rates of successful tumor removal, indicating that this could be the right patient to candidate for surgery. The predictive score that we developed based on these factors could be a very useful tool that could help in the decision-making process that, as we said, is quite complicated for endometrial cancer, as we have plenty of options going from surgery to radiotherapy to systemic therapy. So we think that providing an objective tool like these scores and identify specific variables that can help the surgeon to decide whether his surgery could be really beneficial to that patient is a very useful and necessary tool that we need to know during the multidisciplinary tumor board.
So now let's get into some of the questions from our fellows in the journal. And this first question is from Ali Straubhar. She is in Salt Lake City. And Francesco, I'll ask you. She asked, can you please provide a bit more detail regarding location and approach to treatment in those who have parenchymal spread of disease?
Now, a study, the hematogenous or parenchymal spread group included patients with metastases in various abdominal and extra-abdominal organs, each of which was accurately identified by radiologists and treated according to multidisciplinary disease. We had two isolated bone cases, 3 brain, 18 lung recurrence, 1 spleen, and 2 liver cases. As you see, lung is very, very often found in our population. To address these metastases, each case was managed by a multidisciplinary team, especially for lung and brain and bone metastases. For lung metastases, patients underwent lobar or atypical resection based on the extent of disease. Bone metastases were managed with resection of the proximal tibia and proximal femur in the other case. For liver involvement were treated by atypical liver resection, spleen metastasis by splenectomy, and patients with brain metastasis with craniotomy and resection of the brain lesion where neurosurgery were involved for sure.
Interesting. So yes, quite unique approaches, and certainly, particularly considering very extensive or aggressive surgery. Virginia, I'll ask this question that comes from Spain, from Elena Rodriguez, and she asked, "Did you evaluate the relationship between the imaging test performed and the achievement of complete secondary cytoreduction in patients who underwent surgery?"
Yes, actually, the radiological findings were among the main feature that we used to build the score. So the radiological data and the radiological tests were of paramount importance in our score and in our work. This data played a crucial role in the decision-making algorithm, both for selecting patient candidates for surgery and specifically also the findings were incorporated to assess factors like the numbers of location, the size of location, and also to evaluate the proximity of the lesion to critical structure. So all this information helped the multidisciplinary team to evaluate the feasibility of achieving the complete gross resection, and most of all these features were incorporated into our score to design the algorithm.
So then, to that point, this question from Ali Strobhar again, she asked, a large portion of the patients had CA-125 values collected. While not included in the final model, it was a significant value in the univariate model. The utility for following this in surveillance is controversial or mixed. Should this be a part of the perioperative workup for considering secondary cytoreduction in endometrial cancer, and what other diagnostic interventions should be used? Francesco?
Yes, so after discussion with our statistician, we decided that since CA-125 was not included in the final predictive model because it was unavailable for a significant portion of patients, 68 out of 186. So we know that it's very easy to have on this blood test, and probably in the future we can try to integrate this marker in order to have a better definition of a score in order to identify patients to be submitted to secondary surgery. I'm really convinced that we lost the attitude to ask for 125 in endometrial cancer, because sometimes we have recurrence peritoneal recurrence without expression is a very different marker compared to ovarian cancer. So it's not so clear, it's all, but probably we can work on this.
Yeah. This question comes from Mina Dagis in Turkey. And Virginia, I'll ask you. She says, while age less than 65 has been identified as a key predictor for successful selection for secondary cytoreductive surgery in recurrent endometrial cancer, how can the proposed scoring system be adapted to account for the heterogeneity among patients over 65, particularly those with a high performance status and a favorable clinical profile?
Yes, actually, is it true that the age under 65 is a key predictor, is one of the key predictor that we use in our score? However, the score is composed by also the number of lesion and the size of and the location, the type of recurrence, so lymphatic or hematogenous. So we just don't focus on the age. Of course, a patient that is younger, so it's under 65, as like a point over the other. But if we have a very fit patient with a single site lymph nodal recurrence, this patient can also fit in the algorithm, and so is also considered as a surgical candidate. However, of course, we have always to balance the clinical characteristics of the patients, and another tool that we can consider, and we consider in the algorithm, is the diagnostic laparoscopy that we usually perform before surgery. So if we are uncertain and we have doubts, maybe we can think that the patient is very fit, even if he is older than 65, we can perform a diagnostic laparoscopy and have another point to add to our score and decide to go or not for surgery.
Excellent. So you mentioned about the diagnostic laparoscopy, and this next question comes from Susanna Del Frati from Italy. She's asking what surgical approach was employed for secondary cytoreductive surgery? What criteria should be used to select minimally invasive surgery versus open surgery?
I think that in this study, primarily we did not specifically assess the choice of surgical approach, as the scope included also extra-abdominal disease. So we cannot do this type of analysis. So we cannot do comparison between abdominal standard or minimal invasive approach. But I can say that we are now performing a retrospective review of our experience also in a multidisciplinary setting, and giving some data about the comparison of minimal invasive approach compared to abdominal approach in abdominal disease. And we sent the abstract at the upcoming ESGO meeting in Rome 2025. It is an occasion for us to invite all of you in our city for the next ESGO meeting.
Oh, absolutely.
To see the answer to this question.
We'll be there.
Yes.
So Virginia, this question comes from Roberta Masobrio, also from Italy, and she's asking the AGO score for secondary cytoreductive surgery in ovarian cancer includes the ECOG performance status. In your study, it did not emerge as an independent predictor of complete gross resection in a multivariate analysis. What do you think might explain this result?
Yes, actually, unlike the AGO score, we set the point of the ECOG performance status to 1. So we consider patient with an ECOG performance status of 0 or 1 still fit for surgery. Unlike the AGO score that consider just patient with an ECOG of 0. Additionally, there were very few patients in the bulking group with an ECOG score of 2 or 3. So what can I imagine is that this low number of patients may have contributed to the variable not retaining the statistical significance in the multivariate analysis. So I think that could be the reason.
Excellent. So I'll turn to you, Francesco, and this again comes from Susana Del Frati. She's asking, from your analysis, it appears that the patients who underwent secondary cytoreductive surgery had a more favorable tumor-related characteristics, like a single site of recurrence. So how can it be explained or justified that almost 3/4 of these patients still underwent adjuvant treatment? Should or could these patients just undergo surgery?
I can say that mainly for 2 reasons. One is that guidelines recommend to consider chemotherapy after secondary cytoreductive surgery, and second, there are no comparative trials that compare again chemotherapy versus surgery alone. So we have no data to support the possibility to spare chemotherapy after surgery. So in our institution, and I can say in Italian institutions, adjuvant chemotherapy is generally advised for advanced and or recurrent endometrial cancer, even when complete gross resection is achieved. Also because when we have a recurrence of disease, we consider her with a systematic disease. So we always consider chemotherapy, and probably in the new era of immunotherapy, also immunotherapy together with chemo.
Excellent. So this question comes from Arthur Shu. We all know him, and his question to you, Virginia, is: in the current era of Ruby and GYO18, would you give adjuvant chemo and immunotherapy for patients that had complete gross resection after secondary cytoreductive surgery?
Thank you. This is a very insightful question that opens an important and underexplored area of discussion. Although we currently lack studies specifically examining the use of adjuvant chemotherapy and immunotherapy for recurrent endometrial cancer post-complete gross resection, various combinations of these treatments have shown promise in other cancers and could be considered. Like immunotherapy may play a valuable role as adjuvant treatment for patients with complete gross resection, and this has already been showed in cancers like melanoma, And additionally, also immunotherapy has shown benefits both as neoadjuvant and adjuvant treatment in renal and lung cancer. These findings comes mostly from initial diagnosis rather than recurrences. However, what I think is that these findings could be translated also in the recurrent setting. So I think that like recurrences is mostly a systemic disease, immunotherapy can play a role even in the complete gross resection patients.
Yeah, that'll be interesting to see those data as we evolve with the use of immunotherapy in combination with chemotherapy as well. Francesco, I'll turn to you. Roberta Masobrio, she's asking, all patients considered eligible for secondary cytoreduction underwent diagnostic laparoscopy. In your opinion, could these preliminary evaluations be omitted? Is there a patient population you just go straight to laparotomy?
Pedro, you know that in Italy, especially in Rome, diagnostic laparoscopy for cancer, gynecological cancer, is essential. We proposed it for advanced ovarian cancer, and you know the history. And we also demonstrated for recurrent ovarian cancer that the assessment by laparoscopy can be helpful for really identify patients to be submitted to cytoreduction. We strongly believe in the importance of perform diagnostic laparoscopy in all cases because we can really define the strategy, select patients for minimal invasive approach because only after seeing the disease we can say if we can or not remove it by minimal invasive approach, sparing laparotomy, not sparing laparoscopy as the diagnostic tool, and also to assess the complexity of surgery. So we routinely perform laparoscopy in all cases. The only limitation is in case of palliative surgery, when you have obstruction, or case with severe adherence that cannot allow us to do an evaluation of abdominal cavity.
Excellent. Interesting question here from Elena Rodriguez, and she's asking, and I'll ask you, Virginia, what role do you think surgery has in the setting of recurrences after a secondary cytoreduction? In other words, a tertiary cytoreduction.
Yes, the tertiary cytoreduction obviously increases the complexity of the surgery. So I think that we have to strictly select the cases even more than the secondary cytoreduction. However, I think that there is space for tertiary cytoreduction. We must consider a favorable time to recurrence. So, of course, patients that maybe show a lower disease progression could benefit from a tertiary cytoreduction. And then, of course, we need the collaboration with the radiologist to assess the true resectability and the surgical complexity, as well, together with the oncologist to discuss the therapeutic option. And here we have, again, the immunotherapy setting. So I think there's a lot to discuss about.
Yeah, future studies coming. So just a few more questions, and you guys have been great, and I've really enjoyed this discussion. But just a few last questions. Francesco, what do you think of the limitations of this study?
One limitation is the fact that we have a preselection of patients because all patients admitted to surgery were preselected at the MDT evaluation. The selection process means that our court already met specific criteria favoring surgical intervention, which may limit the applicability of our findings in all patients with recurrent disease. Additionally, it is a retrospective study. All we know how can be the bias of this type of study. And someone can say that this is a study performed in a high specialized tertiary level. But I really believe that this type of patients should be treated in this type of centers. They cannot be considered in all hospitals. And we are now working on an external validation of our score, like the history of the IJGC score, because we have retrospective data. We want to do an external validation and try to design a prospective trial on this score index.
Excellent. So as a last question to you, Virginia, I'll ask this question. It comes from Jose Carlos Vilches in Spain. And it's a question that I typically always ask at the completion of the podcast to the authors. What do you do in your center? So in Gemelli, a patient comes in with a recurrence of an endometrial cancer. What's your process of, your algorithm as you think about how do I manage this patient?
Yes, especially for recurrences, every patient that comes to Gemelli Hospital with a recurrence is discussed at the multidisciplinary tumor board. In this tumor board, we have the radiologist, the oncologist, and the surgical oncologist, and usually we also have the anatomopathologist. So we decided and could perform in a high rate of secondary cytoreductive surgery with a high rate of complete breast resection, just because we started our process with the MDT meeting, where the radiologist, oncologist, and gynecologic oncologist discuss and try to stress and all the aspects of the specific disease. So we are supported by the radiological imaging, and we stratify the patient trying to determine the treatability for surgery. Following this, we proceed, as we said, with the diagnostic laparoscopy that is like an essential step before all surgeries for cancers. In fact, as we reported in our study, approximately 18% of patients that have been selected for surgery actually were deemed not operable after laparoscopic diagnostic laparoscopy. So even an accurate MDT meeting, even with the imaging of the radiologist, we still have a part of the population that fails and need a diagnostic laparoscopy. So also to answer the previous question, diagnostic laparoscopy is a very important tool to avoid unnecessary laparotomy and delay treatment. To conclude, after the publication of this study, we try to integrate the algorithm that we proposed in the paper in the MDT in the MDT meeting, try to refine the patient selection, and try to enroll most patients in the cytoreductive surgery, because the reason we designed this study is that maybe too many recurrences of endometrial cancer could not be candidated for surgery while the complete breast resection was still achievable.
Well, thank you both so much, Virginia, Francesco. I've really enjoyed speaking with you on this topic, this important paper. We're really looking forward to the Journal Club to discuss this manuscript as well. Congratulations to you and to all of the co-authors who participated in this study. I'm sure it was a great deal of work and to ultimately see the completion of the study. Certainly we're all very, very happy that you have submitted it to our journal. So I want to thank you. And once again, congratulations to the team at Gemelli for all the continued contributions that they're making to gynecologic oncology.
Thank you.
Thank you very much.
And see you.